Hello, everyone, and welcome to our second lecture on marijuana. So in this section, we've been talking about marijuana or cannabis. Uh, Last time we talked about the history, both the ancient history and the more recent history in the United States, particularly with regard to the regulatory status. And this time, we'll unpack a little bit more about what marijuana does to the individual. So what are the effects on the brain, and what are the consequences of long-term use? In particular, we're going to learn how marijuana affects the brain, mainly in the form of THC, um, but we'll mention some effects of some of the other compounds in marijuana as well. Remember that marijuana has a wide variety of compounds in it. It's one of these drugs that we describe in terms of its source, the plant. So there's alcohol, which can come from several different sources, but it's just one molecule. Tobacco has a variety of molecules in it, but really just one psychoactive one. Uh, but here, marijuana has a variety of psychoactive compounds, and we're still starting to understand what all the compounds are and what they do. So we'll also look at both the acute effects of marijuana and the long-term chronic effects of heavy use. And here again, there are going to be some uncertainties. So this is started to be studied fairly recently, and we're starting to uncover some of the long-term effects of marijuana use. As with most things, it turns out that uh, there are some benefits to marijuana medicinally, but there are also some negatives. So there is no free lunch. You can't have uh, one of these one of these drugs that is universally good, but it's also seldom the case that something is universally bad, um, at least in terms of your health. We'll also talk about marijuana's current legal status and how that's changing. That, of course, is a topic we're all familiar with here in Colorado. So we'll talk a bit about that, both medical marijuana and legal changes with regard to recreational use. Okay, so when it comes to the brain, marijuana, like alcohol, has a variety of effects, and not all of them are particularly well understood. One thing that was discovered in the 80s was what are called cannabinoid receptors. We recall from last time, cannabinoids are compounds that are found in cannabis, and in particular, they're the compounds that are specifically found in cannabis and not found in other plants. And these are a related set of compounds. We recall from last time, the structures of THC and cannabidiol are very similar. So the question is, anytime you find a receptor, um, oftentimes in history we have found the receptor for an artificial compound or an exogenous compound before we figured out why the receptor was there. That is, what binds to these receptors normally. It's unlikely that we would have evolved receptors for some outside compound that only relatively recently humans have started to encounter. So usually these compounds have some endogenous agent, just like we have dopamine receptors and serotonin receptors and norepinephrine receptors. These are compounds that are produced by the body. And so sure, there are other drugs that we can take into our bodies that alter the function of these receptors, but the receptors originally evolved for those neurotransmitters. Similarly, we found in the 80s these cannabinoid receptors. So the question is, what compound in the body normally binds to these receptors? It took a while to answer that question. What was easier to answer was how many kinds of receptors are there? And it turns out there are two main kinds. There are what are called CB2, CB for cannabinoid, and 2 because it was the non-brain-based receptor. And CB2s are mainly found in the immune system. And it's a little unusual because the connection between cannabinoids and the immune system still isn't fully understood. And in fact, it takes a large dose of THC to affect immune function. But the other one, the other receptor, and the one more relevant for our purposes, is the CB1 receptor. And these are found in particular regions of the brain. They're somewhat widely dispersed, but they're heavily concentrated in the basal ganglia, which, if we recall, is an area toward the center of the brain that includes things like the putamen, the caudate, and so these are areas that are involved in both reward processing and controlling movement and initiating movement. Also the cerebellum, which is involved in certain kinds of learning, but also in coordination and balance. And then the hippocampus. And the hippocampus is one of the most famous structures in the brain, and we've talked about this one before. The hippocampus seems to be heavily involved in memory. So these are structures near the temporal lobes of the brain, so on the sides. And if you lose both of your hippocampi, you can't form new memories. And this has been documented most famously in a patient named HM, who had both hippocampi surgically removed as a treatment for epilepsy. And the treatment worked, but it was found he couldn't form any new memories. And so as we'll see, this makes a certain sense with regard to what the effects of THC are on the brain and on cognition. Eventually, we did discover what are called endocannabinoids. Endo because they're endogenous, they're native to the body, and cannabinoids because they bind to the cannabinoid receptor. The first of these was what's called anandamide, and it was hard to find because it doesn't occur in large concentrations. There have since been others that have been found, and these are things with names like 2-AG. It's actually far more common in the body, but these things seem to be involved in regulation of metabolism, for example, and also analgesia, so pain control. And so not surprisingly, these are some of the things that exogenous cannabinoids, like THC, have an effect on. So what does marijuana and THC in particular do to the individual? So the first question is generally, what does marijuana do? So sometimes, especially in older textbooks, marijuana is classified as a depressant. And while it has some depressant-like effects, currently it's not really classified as a depressant. It's sort of its own class of drug. Alcohol is certainly a depressant, even though it has some paradoxical effects. But marijuana, for example, has a non-depressant effect on the cardiovascular system. And also in sufficient doses, it is a hallucinogen, which is not an effect that you see for depressants. So it has sort of an interesting mixture of properties. So it's not classified as a depressant. So you may see some textbooks that do that, but generally it's not currently considered a depressant. So what physiologically happens is you get an increase in heart rate. And again, this is one of the reasons that we don't classify it as a depressant. It actually stimulates the cardiovascular system. It also has an augmenting effect on appetite. And when we talk about medical marijuana, this will be an important effect of cannabinoids and THC in particular, as they seem to increase the sensation of hunger. There's a question whether marijuana increases blood pressure. Studies are not entirely conclusive on this topic. It's generally considered that for younger, healthy users, that it doesn't have an adverse effect on blood pressure. At the same time, for older users, especially ones with cardiovascular illnesses, it's advised that you not take THC in any form because it increases heart rate. And as we know, increasing heart rate, increasing the number of beats the heart performs per minute, is also going to increase blood pressure on average. So again, it's not clear whether acutely marijuana increases blood pressure, but if you're old or you have a cardiovascular condition, it's better to be on the safe side. It doesn't seem to have an acute effect on lung function. So as we'll see with chronic use, it may, but in the short term, just using a single dose of marijuana doesn't seem to impact pulmonary function in any appreciable way. One of the interesting things about marijuana is, unlike so many of the other drugs we talked about, it's almost impossible to get a fatal overdose, which isn't to say that you can't die from the other effects, especially if you're driving. Um, but there really is no amount of THC for an adult, for a healthy adult, that will be lethal. And that's interesting because things like the depressants, eventually you'll stop breathing. The stimulants can also eventually have sort of a paralytic effect on the cardiovascular system and you'll die. There are a lot of different drugs that you take too much, it'll kill you. But not so for marijuana, which makes it a very unusual drug in our class. That being said, there have been reported cases where small children came across usually edible forms of marijuana and ingested what for their size is a massive amount of THC, and they fell into a coma. So death by overdose, not possible for an adult. Uh, it's unclear if it is possible for children. And of course, as we'll see, children are and adolescents are more affected by marijuana developmentally than adults are. So it's best not to expose children to THC or marijuana anyway. So what does it do to cognition? So we've described these receptors the brain has and where they are in the brain. And not surprisingly, the effects that it has on cognition um, map onto those areas fairly well. Not entirely. We don't understand why all the effects of marijuana occur the way that they do. But for example, THC is reinforcing. Animals and humans will expend effort in order to get THC, whether it's intravenously or ingested. So THC does seem to have some reinforcing effects, which, as we've already seen, is usually a risk factor for dependence. It certainly is for things like cocaine. However, marijuana itself is not physiologically addictive, and its psychologically addictive potential is pretty mild relative to other drugs. It's not to say that it doesn't exist, but relative to others, it is fairly mild. There's also an important effect of experience, and this is something we've come across a number of times, especially for things like alcohol. So the behavioral and cognitive effects of alcohol are diminished uh, in the case of someone who is a regular user of alcohol. Um, Nevertheless, you do have acute effects, so short-term effects from a single use. And these are usually euphoria, and this ties into the effects of cannabis on the basal ganglia, which process reward, and also relaxation. So this is the sense in which marijuana is like a depressant. So you usually get a sense of relaxation, but you also get that euphoria, that high. And one of the theories about those two effects has to do with uh, the ratio of THC and cannabidiol. It's thought that cannabidiol has more of a depressant effect, and THC gives that euphoria, that high. Of course, both compounds are present in marijuana, but whether it's cannabis sativa or cannabis indica, those ratios can change. They can also change as a function of when the plant is harvested. In certain users, particularly first-time or non-regular users, you can also get paranoia, so anxiety and the sense that someone's out to harm them. You also get diminished task performance, and this is one of those areas where you don't see this effect as much in heavy users and regular users of marijuana. However, for first-time users or infrequent users, you get diminished task performance, decreased attention, decreased memory performance, uh, and generally in any sort of attention-based decision-making task, you have this decreased performance in, but generally just in infrequent users. Now, if you take marijuana in a high enough dose, you can get hallucinations. So this is why traditionally some cultures used marijuana as an entheogen, which is something we talked about weeks and weeks ago. So a religious practice uh, in which one takes a drug in order to create hallucinations and have a spiritual experience. Um, you know, the legitimacy of the spiritual experience is not our topic today, but that is what cultures have used marijuana for in some cases, especially in religious cases. Uh, but it takes very high doses, and it's even so, it doesn't occur for all users and for all types of marijuana. This is another issue where the strain or species of marijuana and the compounds inside that particular dose are particularly important. And when it comes to the impact on driving, this has been well studied, and well studied in two different respects. First, there's just a general statistical study of car accidents and looking at whether a disproportionate amount of people involved in car accidents have been using marijuana. The other is actual laboratory studies of performance. So these are things like driving simulators, where someone is given a controlled dosage of THC, and then you look at things like reaction time, responsiveness to stimuli, attention. And here, the laboratory studies do indicate a worsening of performance in driving. Statistically, it's not as clear. So there is not overwhelming evidence that a disproportionate number of accidents involve marijuana. Um, but there are a couple of things to be mindful of here. One is that marijuana, especially in young users and when a car accident is involved, usually there's alcohol in the person's system also. So it's hard to tease apart those two, uh, the effects of those two compounds. Uh, and second, there just isn't as much marijuana use in terms of involvement in accidents. So the frequency of marijuana users in car accidents isn't nearly as high as alcohol use is, just because there are more people who use alcohol. Uh, so the picture isn't entirely clear there. It may just be because of statistical difficulties, but there may be an actual effect of marijuana on driving ability. And that's still a heavy area of research for obvious reasons. So that's all acute effects, the short-term effects of marijuana. What are the chronic effects, the long-term use? So one of the questions in psychology currently, um, it's pretty clear that marijuana doesn't cause physical or physiological dependence. The remaining question is whether one can be psychologically dependent. That is, to have cravings and have difficulty controlling behavior. Um, so nevertheless, despite the fact that there's no real strong evidence for physiological dependence, we can still ask if there's such a thing as marijuana withdrawal. So heavy users have sometimes reported things like increased anxiety or insomnia or a decrease in appetite after stopping marijuana use, after a long period of heavy use. And this makes sense. So because marijuana causes relaxation, can cause drowsiness, and is an appetite stimulant, when you suddenly take the marijuana away, they take it out of the system, suddenly the opposite of those effects arises. But these are mild cases, and even in laboratory studies where people are administered very large doses of THC for long periods of time on a very regular basis, these effects are still pretty mild and fairly inconsistent. Um, so whether these things qualify as withdrawal symptoms, it's not exactly clear. There are some things that it's been shown that marijuana doesn't really do. Very early on, especially the early part of the 20th century, when there was a lot of public sentiment directed against marijuana. Um, remember, the Marijuana Tax Act of 1937 was promoted uh, thanks to a number of stories about violent marijuana users. And there was almost immediately a questioning of the validity of these effects. And it since has been shown that marijuana doesn't really increase aggression. In fact, if anything, it decreases it. Now, one of the possible withdrawal symptoms that a few individuals have mentioned is an increase in aggressive behavior. Whether that's just an offshoot of an increase in irritability is not clear. But one thing that is clear is that the use of marijuana doesn't seem to increase aggression at all. Uh, so the idea of the violent marijuana user seems to be mythical. Uh, One thing that wasn't that may have caused this story to arise is that again marijuana is often used in combination with alcohol, and alcohol does increase aggression. So it just may be that the behavior was wrongly attributed to the marijuana use, given that the marijuana use was getting more attention at the time. However, it was a long time ago, and we'll probably never know. There was also marked what's called amotivational syndrome, which is sort of a general lack of willpower, a general lack of interest in physical activity and achieving goals. Uh, and again, even heavy marijuana users don't seem to actually exhibit this trait consistently. So this seems to be another effect that was sort of imposed upon our concept of marijuana use, but doesn't really have any scientific basis. So one thing that marijuana does affect is lung function chronically. We've already said that in the short term, lung function isn't really affected by marijuana use, but repeated smoking of marijuana does seem to cause pulmonary dysfunction, difficulty breathing. There's a question as to whether it causes cancer. The jury is still sort of out on that. Um, Marijuana smoke contains a lot of the same compounds as tobacco smoke. In fact, on average, it contains more tar, which is that collection of hydrocarbons that are thought to contribute to the carcinogenic effects of tobacco. Um, so the thing is that marijuana users typically don't smoke as much in terms of volume of smoke as tobacco users in a single day. So while the smoke may be as toxic or even maybe a little more toxic than tobacco smoke, the fact that it's inhaled less frequently suggests that maybe it may not be as harmful in terms of lung function. However, on the other side of that coin, when marijuana users inhale marijuana, they tend to hold the smoke in their lungs longer. And so again, we have this trade-off of effects: frequency of smoking versus how often marijuana is smoked versus tobacco, and how long the smoke is in the lungs for. Marijuana also seems to have an effect, particularly on male reproduction. It doesn't really seem to affect female reproductive capability. Nevertheless, it can affect children. So pregnant women are, of course, advised not to smoke marijuana. Um, it does tend to lower sperm count in men, so it does seem to affect the reproductive system. There are, in fact, cannabinoid receptors uh, on the cells that are responsible for producing sperm. And again, for women, it doesn't increase the risk of miscarriage or doesn't seem to affect birth weight. Nevertheless, the effects of THC on the developing brain aren't terribly well understood. And so marijuana is probably best avoided, like most drugs, for pregnant women. As I mentioned a couple slides ago, uh, cannabinoid receptors, the CB2 receptors, found heavily in the immune system. And marijuana and THC have been found to impact the immune system, but only in really large doses. Why the immune system expresses cannabinoid receptors is not clear. That's still an area of active research, but they are there. In terms of the effect on neurons, so it has been claimed at times that marijuana use kills brain cells. This is another one of those claims that the evidence doesn't really bear out. So even heavy marijuana use doesn't seem to actually kill neurons. However, it does seem to affect memories. And in particular, it seems to affect the formation of memories. So people that use marijuana don't have any trouble recalling information as long as that information was stored, as long as they made that memory not under the influence of marijuana. So it's not the recall of memories, it seems to be the storage of memories that marijuana affects. And there have also been laboratory studies that suggest that neurons are less likely to form connections uh, under the uh, influence of marijuana. So it doesn't kill the neurons, but it may keep them from forming connections, forming synapses with one another. And as we've already talked about, synapses and modulating synaptic function are thought to be the mechanism for memory formation. There's also a question of whether marijuana causes psychosis. So there has been a correlation that's been recorded between the appearance of psychotic symptoms and marijuana use. And again, here we have to be careful. We have to think about where these data are coming from. So that's one. It is possible that marijuana increases the incidence of psychotic symptoms. Um, but we also have to be aware of how these data are collected in terms of the questions that are being asked. So the individual may self-report, may tell the experimenter or report on the survey that they've experienced certain symptoms, um, but whether that qualifies them as having experienced a psychotic episode, for example, is not as clear. Um, Also, it could be that rather than marijuana causing the psychotic symptoms, that the psychotic symptoms cause marijuana use. As we saw in our unit on tobacco, uh, there's a overwhelming proportion of patients with schizophrenia that smoke. Uh, it's 4 times as common in schizophrenics as it is in normal population. So it may be that those with psychotic symptoms are in some sense self-medicating, or it could be that some other symptom of psychosis leads to marijuana use. And there's always, of course, the phenomenon of common cause. It may be that both psychotic symptoms and marijuana use are resulting from the same developmental effect or environmental effect. One thing to be aware of is for all of these chronic effects, uh, for the most part, these chronic effects seem to have more to do with when the user started smoking marijuana as opposed to how long or how often they've been smoking it. So these chronic effects are all more severe for those that started smoking marijuana heavily during adolescence. If you didn't start smoking until you were in your 20s, the effects are severely mitigated, so not as severe. So that's one thing to keep in mind, and it's one thing that our discussion this week will talk about. And we'll look at how we regulate, how we should regulate, how we do regulate the use of marijuana by adolescents, given that it has a bigger impact on that population. Okay, so recently, that is in the last couple decades, uh, there's been the idea of medical marijuana. So historically, of course, marijuana has been used in religious ceremonies, but also as a medicine, particularly as a pain reliever, so for analgesia, and as a digestive, a way to increase appetite and suppress nausea. So these uses have been known for a long time, and in fact, marijuana was used in this way up until the early 20th century. Now, part of this was societal, but another part was medical. This decline in the use of marijuana as a medicine. And the reasons for this uh, there are a few of them. One is the rise of pharmaceuticals. So in the early 20th century, the medical community started to develop drugs that were more effective than marijuana for very particular symptoms. So we had more effective pain relievers. We had more effective pharmaceuticals for indigestion or for appetite increase. And so we suddenly had a lot more options for the treatment of the symptoms that marijuana was historically used to treat. Also, as we've already noted, the content of THC, of cannabidiol, varies widely from not just from preparation to preparation, that is from uh, sinsemilla or hashish or hash oil, um, but also just from one plant to another. It's very hard to control the amount of psychoactive compounds that are present. So this variability led to a difficulty in prescribing or knowing how much to use. THC is also insoluble in water. We already talked about how it's soluble in fatty tissue. And being insoluble in water makes it difficult to inject. And it has a long latency. So especially if it's ingested, it can take up to 90 minutes, which is a fairly long time to wait for pain relief, for example, especially if you have a pharmaceutical that is much faster acting. However, starting in around the 70s, some new uses were discovered. One of the earliest and most famous is for glaucoma. So glaucoma is caused by an increase in the pressure in the fluid in the eye that eventually kills the retina and causes blindness. But it was discovered that marijuana can decrease that intraocular pressure and relieve the symptoms and the cause, or that is the direct cause of damage to the retina, in the case of glaucoma. It was also discovered that marijuana could be used as an anti-nausea medication, particularly for individuals undergoing chemotherapy. So one of the side effects of chemotherapy is a loss of appetite, but of course this person is fighting a disease, so they need to keep up with their nutrition. But it's hard to do that if you don't have any appetite. And so to combat the loss of appetite, the loss of interest in food, marijuana has started to be prescribed, and really it's preparations of THC. It has started to be prescribed for chemotherapy patients. And interestingly, preparations, particularly of cannabidiol, have been used to treat certain seizure conditions. They're not very common, but there are seizure conditions, usually in small children, that have been shown to respond very well to cannabidiol, which of course is one of the active compounds in marijuana. So if we recall, marijuana is currently a Schedule I substance. And of course, what qualifies as Schedule I substance is high risk for dependence, negative consequences, and no accepted medical use. Well, now we've got several reasons why marijuana may not belong on Schedule I. First, the no medical use clause doesn't seem to apply because there are now being discovered several uses for the compounds in marijuana. Second, the negative consequences, a lot of them seem to do with the fact that you're smoking the substance rather than the effect of THC itself or cannabidiol. And third, the risk for dependence physiologically seems to be nothing. The risk psychologically seems to be mild. So ever since it was placed on Schedule I, there's been a backlash against that scheduling. And it's thought that it's on Schedule I largely because of its history, especially its history of regulation in the U.S., then because it qualifies on the criteria for Schedule I. So this is an ongoing debate, but an increasing number of states allow marijuana or its derivatives to be prescribed. So that brings us to the legal status of marijuana. So there's a wide variance internationally. So in some countries it is completely legal. In others it is sort of legal in a qualified sense, either medically or recreationally in limited places or in limited quantities. In some places it's still punishable by death. So huge variance in its legality. Of course, in this course we're looking mainly at the United States, and there have been some recent changes in the United States law governing marijuana. And one of these has been a move toward decriminalization. That is the removal of penalties like jail time for the possession of marijuana. A large portion of our prison population are in prison for drug-related offenses. And as a society, people have started to question whether that is a good use of resources, whether that is an appropriate penalty, and whether that is an effective way of treating drug use and drug abuse in our country. And again, as mentioned, there are an increasing number of states that have allowances for medical use of marijuana. And so here is a table on the left from your book that shows which states have medical marijuana laws and how much you are allowed to possess in those states. Now, of course, here in Colorado, we know better than anyone that there are also states that have legalized marijuana for recreational use. So here in Colorado, we have recently enacted that law, and again, it is a hot topic. It even varies regionally, whether within Colorado, whether marijuana is legal or not. Um, it has been a large source of tax revenue, but there's some question as to the rise in marijuana use, perhaps in adolescence. Again, the legislation is too recent to make any strong claims about the effects of legalization in this state. Washington, D.C. has also recently legalized, although Congress stopped the sale of marijuana, the possession and use is legal. And some other states like Oregon, Alaska actually, and Washington have legal recreational marijuana use. And of course, in a lot of states, again, we have this decriminalization or laws that are criminal but aren't really enforced very strongly. So this is a recent trend. And again, time will tell whether this is a wise course of action or not. However, since marijuana has historically been illegal and the marijuana laws are enforced in many places, we've also seen the rise of what's called synthetic cannabis. And this is often marketed under names like Spice or K2. And so these are mixtures of compounds, of which a large portion is synthetic cannabinoids. As mentioned last time, there are a large number of cannabinoid compounds, and we don't even know what all of them are. We certainly don't know what their effects are, either acute or chronic. So it's difficult to say how safe these compounds are, um, and so it is generally discouraged. Uh, that their use is generally discouraged uh, because the fact is that we just don't know what all of these compounds do, and certainly what all of them do in combination with one another. It's going to take a long time to fully research all of the cannabinoids that are being put into these mixtures. And this is something we talked about way back in the very first lecture of the course, is trends in marijuana use. So this was our example of drug use and the history of drug use. But just to refresh, since we are talking about marijuana, um, here is a graph from your book. And one thing we notice is that there was a peak in marijuana use in the late 1970s, early 1980s. By the early 90s, the use of marijuana had sort of bottomed out. It was not at zero, um, but it was lower than it had been for a long time. And of course, those in high school or college age are more likely to use than younger adolescents. Um, other thing to notice is that marijuana use is back on the rise, and of course that may stem in part from it being decriminalized, from it being more acceptable to use marijuana. So it could be a social phenomenon. Um, and of course, we've already talked about how the social perception of a drug can affect its popularity. Um, and so here we see trends over history where individuals were asked to divulge how frequently they use marijuana and to assess how available they thought marijuana was and how risky they thought marijuana use was. And it turns out that increases and decreases in marijuana use aren't really due to the availability, or at least the perceived availability of marijuana, but rather the perceived risk of using marijuana. So these are some sort of large social trends over the last couple decades. Okay, so that will do it for our unit on marijuana. Next time we will talk about hallucinogens, of which there are a variety of types. And so we'll go over where hallucinogens come from, how are they classified. We'll talk about their history of use. Many hallucinogens are naturally occurring. And so as with alcohol, tobacco, marijuana, they have a long history of use by different societies and cultures. And they also have a wide variety of effects. And of course, hallucination, or at least altered perception, is what unifies the category of hallucinogens. But they affect different brain systems, and we'll talk about that as well. So that will do it for today, and I will see you next time.